Hello everyone, welcome to ETH I'm Dr. Yosafit Aberra. Today we will discuss about primary hemostasis. We will discuss starting from your previous National Licensure Exam question. A 26 years old female presented with 2 months of excessive menses and, gum bleeding. And physical examination revealed pale conjunctiva, petechiae, ecchymosis. Which of the following is most likely diagnosis? A. Hemophilia. B. Idiopathic thrombocytopenic purpura. C. Scurvy. D. Vitamin K deficiency. Please pause your video and have your answer. So in this particular question, they want you to know about or to differentiate the primary hemostatic disorder from the secondary hemostatic disorder based on the clinical presentation. So in short, does this patient have a primary hemostatic disorder or secondary hemostatic disorder? So let's have discussion. So primary hemostasis is a process involved in the formation of platelet plaque, or sometimes called white thrombus. And as it said, platelet plaque is so said white thrombus because they lost erythrocyte or red blood cells. And in secondary hemostasis, the clot is called red thrombus because they have adequate erythrocyte or red blood cells. So following endothelial injury. So clinical presentation of primary hemostatic disorder is mucosal bleeding and skin bleeding. Mucosal bleeding like hematuria, mucosal bleeding like hematuria, uh, GI bleeding, GI bleeding, gum bleeding, gum bleeding, other mucosal bleeding like hemoptysis, and also very important presentation like epistaxis. So in addition to those mucosal bleeding, and if the patient presents with this mucosal bleeding and have skin bleeding in addition to those like petechiae, and also we call petechiae whenever there is bleeding in the skin that is very small and like pinpoint, we call it petechiae. And also other term like purpura, and we call purpura if the diameter of skin bleeding is greater than or equal to less than or equal to, less than or equal to 3 millimeter, we call it purpura. And also if the diameter is greater than 1 centimeter, we call it ecchymosis. And also the other skin bleeding manifestation is easy bruising. Easy bruising. Easy bruising. So this is characteristic of this manifestation are characteristic of primary hemostatic disorder. If the patient have secondary hemostatic disorder, the patient presented with deep tissue bleeding, like bleeding to the muscle, as well as bleeding to the joints. The term used for bleeding to the joint is called haemostasis, and also other deep tissue bleeding like post-surgical or post-dental procedure bleeding, like after tooth extraction. So those are the common manifestation of or typical manifestation of secondary hemostatic disorder with deep tissue bleeding. So this primary hemostatic disorder is especially common in young female patients. So let us discuss about the physiology of hemostasis. So the initial step, the very first or initial step of after endothelial injury is vasoconstriction, transient vasoconstriction, and it is this transient vasoconstriction is mediated by two mechanisms. One is as neuroreflex. So neuroreflex or neurostimulation can cause transient vasoconstriction. The second is the injured endothelium produce a substance called endothelin, and this endothelin is a vasoconstrictor, and by that transient vasoconstriction, they can limit the amount of blood flow. So uh, the second step is addition, platelet addition. So this is endothelium. By the way, this is endothelium, and this is subendothelial tissue, and this is collagen. Look at this. This is collagen. This is collagen. So this is von Willebrand factor, substance called von Willebrand factor, and this is very important that this platelet, the platelet, in order this platelet become adhere to the injured site, they need von Willebrand factor, and this von Willebrand factor is is found from the Weber Palladi body from the endothelium, and this endothelium contains this Weber Palladi body, and this Weber Palladi body stores this von Willebrand factor, and whenever we sustain injury or endothelial injury, the von Willebrand factor will be come out from the Weber Palladi as well as from the platelet, especially with as alpha granulation. So these platelet come to contact with through this von Willebrand factor to the injured site, and by the receptor called. So there is a receptor in the platelet, which we call GP1B receptor, and this receptor is useful to have contact with the von Willebrand factor, or in short, GP1 receptor is useful to have contact with the von Willebrand factor. So whenever this uh, whenever platelet adhere to the von Willebrand factor to the injured site, they have shape change. Look at this. This was the before platelet adherence, the shape of the platelet was this, and it is changed to this. So the adherence will causes shape change, and this shape change can cause the third step called platelet degranulation, or degranulation of platelet, or activation of platelet. So the activation or degranulation of platelet can produce thromboxane A2, and ADP called adenosine diphosphate. So these two substances, thromboxane A2 and ADP, is very useful to express this receptor. This receptor is called GP2B or 3A receptor in the platelet. So expression of this GP2B 3A receptor is very useful for the platelet aggregation, which is the last step of primary hemostasis, which you call platelet aggregation. Platelet aggregation, and this is platelet aggregation. So one platelet bind to the other platelet through this receptor, and the linker molecule between this GP2B 3A receptor and another GP3A receptor is fibrinogen. Fibrinogen, and this is a weak. Fibrinogen is soluble and it is weak. So the end stage of the primary hemostasis production of this platelet plug, and so this is the weak, very weak, and this platelet plug need coagulation cascade and secondary hemostasis to be strong. To be strong, this fibrinogen should have to be changed to the fibrin, and for this process, fibrinogen change to the fibrin, we need secondary hemostasis steps or calculation cascade. So the end result of this primary hemostasis is formation of this platelet plaque. So let's go to our question. So this patient From those, definitely this patient has primary hemostatic disorder from our discussion. So from the question or from the choice listed, which of this entity is primary hemostatic disorder? So is it hemophilia primary hemostatic disorder? No. Hemophilia is secondary hemostatic disorder. Hemophilia is classified as hemophilia A and hemophilia B, and hemophilia A is a deficiency of factor 8, and hemophilia B is deficiency of factor 9. So they manifest with deep tissue bleeding like muscle bleeding, as well as joint or joint bleeding, haemostasis. So hemophilia is not the answer. B, idiopathic thrombocytopenic purpura. This is the answer. Thank you. This is the answer. So idiopathic thrombocytopenic purpura is the primary hemostatic disorder. It is the primary hemostatic disorder, and we will discuss in short about ITP or idiopathic thrombocytopenic purpura. So the third is C, scurvy. The other name for scurvy is vitamin C deficiency. Vitamin C deficiency. So this vitamin C is vitamin C deficiency is caused by poor intake of fruits and vegetable, because this vitamin C is available in fruits, vegetable, especially in those citrus like in lemon. So this question should have to tell us about the nutritional status of the patient, so that this scurvy patient with scurvy or vitamin C deficiency have poor intake of fruits and vegetable, especially, or the patient may have malnutrition or poor intake because of alcohol abuse or mental illness and other disorders. So SC scurvy is not the answer. By the way, scurvy or vitamin C can cause all the explained symptom, like it can cause menorrhagia, which is excessive menses, and also gum bleeding and anemia, PTK, as well as ecchymosis. So the above explanation or the above history needs nutritional history in order to consider scurvy. Otherwise, scurvy or vitamin C deficiency can cause mucosal bleeding as well as skin bleeding. So the other is vitamin K deficiency. Is vitamin K deficiency primary hemostatic disorder? No, it is secondary hemostatic disorder. Vitamin K deficiency is secondary hemostatic disorder. This vitamin K is very important in gamma carboxylation of factor like 7, 2, factor 2, factor 9, factor 10, factor 10, as well as C and S. So if there is vitamin K deficiency, gamma carboxylation of those factor is affected. Those factor is affected, and their function is affected. So there is no factor 2, 7, 9, and 10, as well as S and C whenever we have vitamin K deficiency. And those are very important in coagulation cascade, which is divided as intrinsic and extrinsic pathway, which is in the secondary hemostatic disorder, which manifests by deep tissue bleeding, like bleeding to the muscle and joint. So let's have brief discussion about idiopathic thrombocytopenic purpura or ITP. So definition: thrombocytopenia of unknown etiology. So the idiopathic production of antibody to the platelet leading to removal of platelet from peripheral circulation by phagocytosis of macrophage. The platelet are bound to macrophage and brought to the spleen, leading to low platelet. So uh, in ITP or idiopathic thrombocytopenic purpura, the spleen will produce antibody against platelet antigen. produce antigen, antibody against platelet antigen. So, for example, the antigen may be this one glucose, GP2B3A. For example, if the spleen produce antibody against GP2B3A receptor, it will destroy this receptor, and so if this GP2B3A receptor is destroyed, there is no platelet aggregation. So, as we discussed before, for the platelet aggregation, so we need GP2B3A receptor. So, if there is no GP2B3A receptor, so there is no platelet aggregation, and the function, there is no platelet plug, so the function of the platelet is affected. So the platelet then, the spleen, then also the macrophage in the spleen will phagocyte this platelet. So, and then it can cause low platelet, and that is why we use the term thrombocytopenia for this disorder, idiopathic thrombocytopenic purpura. So, classification of ITP. ITP classified as one, acute and chronic. Acute is common in children, and especially after upper respiratory, few weeks back, upper respiratory tract infection, as well as immunization, recent immunization. So with this we call ITP, acute ITP, if it is in children. And so special, this is very self-limiting in children. ITP is self-limiting in children. Otherwise, if there is a severe bleeding, or if you consider as if the platelet is very low, like if it is less than 20,000, so you may consider corticosteroid. Otherwise, in children, the ITP is self-limiting. When it comes to chronic ITP, it is in adults, and it is from 20 up to 50 age. And bad thing about this chronic ITP or adult ITP is that is frequently relapse, and it is difficult to treat. And whenever you found ITP in adult, you must have to start corticosteroid, especially the prednisone. So the initial, or the very initial therapy of ITP in adult is initiation of corticosteroid, especially prednisone. So the other classification is newly diagnosed, if it is less than 3 months, persistent ITP, if it is 3 up to 12 months, and it is chronic ITP, we call it chronic ITP if it is greater than 12 months. So findings like normal in ITP, normal spleen on exam and on imaging studies such as ultrasound is a characteristic of ITP. So there is no splenomegaly in ITP. So this may help you to rule out those cause of thrombocytopenia as well as splenomegaly. So in ITP, the spleen is normal, whether in physical examination or in ultrasound examination. The other lab findings, platelet number. Please answer. Platelet number will be low in the ITP or ITP or idiopathic thrombocytopenic purpura. The platelet number definitely will be low, and normal platelets range from 150 to 450,000. So it will be low or below 150. So platelet number is low in ITP. Bleeding time, please. What will be the bleeding time of ITP? It will increase. The bleeding time will be increase. So normally the bleeding time is 2 to 7 minutes. So in ITP, it is more than 7 minutes. So that means if you sustain, or if you needle prick to the patient, and you will wait, or you will count if this clot within 2 to 7 minutes. If it is greater than 7 minutes, that is called increased bleeding time. So the bleeding time is high because of problem with platelet. So peripheral smear in ITP, peripheral smear, it is normal. So this, by the way, this peripheral smear is very important to differentiate from other cause of thrombocytopenia like TTP, and also HIS, or what we call it, uh, hemolytic uremic syndrome. So in those cause of thrombocytopenia, the red blood cell is the structure of red blood cell, for example, is sheared, which you call is spherocytosis. So in ITP, it is normal. So peripheral smear is very important to differentiate to rule out other cause of thrombocytopenia. The other is bone marrow, the megakaryocytes, number of megakaryocytes, it will be normal or increased because the problem is not the production. There is no problem with the production. The problem is with the destruction of platelet. There is increased destruction of platelet. Otherwise, the production is very fair or normal. So megakaryocytes, which are the main cell in the bone marrow for the platelets, is normal or increased production because of increased destruction. So otherwise, it is normal. So treatment. Initial therapy for the ITP, it is corticosteroid, initiation of corticosteroid, especially the prednisone is the initial therapy. Definitive treatment for the ITP, please. It is splenectomy. Splenectomy is the definitive treatment. Definitive treatment. So intravenous immunoglobulin as well as Rohagam is very helpful for those who have life-threatening like intracranial bleeding. So if recur after splenectomy, use this thrombopoietin agents, especially this is very famous, rituximab. So this is how you to treat. No, one thing I should have to add in the lab finding is that PT, 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 PTT, PT as well as PTT is normal in ITP because the problem is the platelet, not in the coagulation cascade. Uh, so PT as well as PTT is affected, or they are a good measure of intrinsic and extrinsic factor. For example, PTT is useful in measurement of intrinsic factor, and also PTT is very important in the measurement or in the extrinsic factor. Sorry, PTT for intrinsic factor as well as pathway, and PT is for the extrinsic pathway. So we don't go to the coagulation cascade. So the problem is in the primary and on the platelet. So the PTT is normal in ITP. So scurvy is a disease of vitamin C deficiency secondary to poor nutritional intake, causing anemia, fatigue, spontaneous bleeding, joint swelling, as well as gingival ulceration. So the patient will bleed because vitamin C or ascorbic acid is a cofactor for collagen synthesis, and it is very primary antioxidant, is rapidly consumed post-wounding. So it is important. Vitamin C is important in the production as well as of collagen, which is important for the wound healing. That's why the deficiency will cause bleeding. So thank you for watching. Please subscribe and share. I need your subscription. It is very helpful, and thank you very much. And we will continue other primary hemostatic disorder as well as secondary hemostatic disorder in next videos.